Hey everyone, it's Sarah with RegisteredNurseRN.com, and today we're going to continue our series on shock by talking about hypovolemic shock. And as always, after you watch this YouTube video, you can access the free quiz that will test you on this condition. So let's get started. Hypovolemic shock occurs when there is low fluid volume in the blood, hence where the name hypovolemic comes from. Hypo means low, vol means volume, and emic means blood. So we have low blood volume. And we're specifically talking about the blood volume in the intravascular space. And this space contains the volume of blood in a person's circulatory system. So if we deplete that volume of blood in a person's circulatory system, what does that leave that heart to pump throughout the body? Not very much. So what will happen, the amount of blood that this heart pumps per minute is going to decrease. And we're talking about cardiac output. So if we decrease cardiac output, the amount of blood that is going to the cells, tissues, and organs is going to dramatically decrease too. So those cells are going to be deprived of oxygen. And when we do that, cells start to die. And then we start seeing signs and symptoms of shock. Now, a person needs to lose about 15% or more of their volume for signs and symptoms of shock to occur. Now, in the average human adult, they have about 5 liters of blood. So if a person loses 1 liter of that 5 liters, they've lost 20% of their volume. So whenever they lose that much, they're going to start showing signs and symptoms of shock. Now let's talk about the causes of hypovolemic shock. So what can lead to a loss of fluid in the intravascular system? Well, any conditions that really cause fluid to leave the body externally, like there's some type of major injury, so that person is just outwardly bleeding, or there is some type of inside shift of fluid leaving that intravascular space. So let's talk about the 2 types of hypovolemic shock. First type is called relative hypovolemic shock. And this is where you have an inside fluid shift from that intravascular system. And this tends to be a little bit more concealed than the absolute type, which we're going to talk about next. You're not going to see just bright red blood leaving the body like how you could in absolute, and you know that that patient's losing fluid. This can be a little bit more concealed. So this is where fluids or blood is collecting or leaking inside the body. And this can occur with internal bleeding or where you have third spacing of fluid, like with severe burns. And this occurs due to increased capillary permeability. And we talked in depth about this in our burns video. In addition, long bone fractures, they're very vascular, can cause a lot of fluid loss. In addition, damage to organs like in acute pancreatitis. You can see this when a patient develops colon or Turner sign. And colon sign is where you have severe bruising around the belly button, and Turner sign is where you have severe bruising on the flanks. And that can indicate that the patient is having internal hemorrhage, and that occurs with acute pancreatitis. And another thing is like massive vasodilation that occurs in sepsis. The next type is absolute hypovolemic shock, and this is where you have an outside fluid shift from the intravascular system, and this is more noticeable compared to the relative type. And this is where fluid is leaving the body externally. You can see it. And this can occur with massive bleeding that's been experienced due to blood loss with surgery or some type of injury, excessive fluid loss, and this can be through the oral route with vomiting, or the GU route, urination or GI, diarrhea, or sweating with your skin. And many times whenever that occurs, it's being caused by some type of disease process. The patient's really sick, so they're just throwing up a lot, or some type of endocrine disorder. Now let's talk about the pathophysiology of hypovolemic shock and tie in the signs and symptoms associated with this condition. Okay, let's say we have a patient who's in hypovolemic shock, and it's due to like either a relative or an absolute cause, but regardless, what's happened is that their intravascular system, their circulatory system, has been depleted of fluid volume. So what's going to happen is that you're going to get a decreased amount of fluid volume that is returning to this heart to be pumped. So we have a low venous return to the heart. That intravascular system has been depleted of it, so there's really nothing to drain back. Now, whenever that happens, it's going to affect cardiac preload. Now, what is preload? This is the amount that these ventricles stretch at the end of diastole, at the end of that filling phase of the heart. So it's the end diastolic volume. Well, if we don't have a lot of fluid volume draining back to that heart, those ventricles really aren't going to stretch. They don't have to stretch because the fluid volume just isn't there. Now, cardiac preload is a determining factor in stroke volume. And stroke volume is the amount of blood that this ventricle pumps with each beat, which should be anywhere between 50 to 100 mLs. Well, when our stroke volume falls, it decreases cardiac output, because remember, cardiac output is heart rate times stroke volume. And cardiac output is the amount that this heart pumps per minute. And it should be anywhere between 8 to 4 liters. But if we have a decrease in stroke volume, that's going to decrease our cardiac output. Now, when we get a decreased cardiac output, this is going to decrease the amount of blood that's flowing to our organs and our tissues, specifically to those cells. So we're going to get decreased tissue perfusion. And what's that magical substance in the blood that cells love? Oxygen. So when you decrease the amount of oxygen that is flowing to these cells, they're going to start struggling. They attempt to try to save themselves at first by switching the way they metabolize from aerobic to anaerobic. But the problem with that is that you're going to get the buildup of lactic acid, which is going to throw off our pH of our blood, entering into acidotic conditions. And then the body's going to try to compensate, and it's going to activate the sympathetic nervous system and the angiotensin, the renin system. It's going to be shunting blood, all in an attempt to help save the body, save those organs. Now, the signs and symptoms of hypovolemic shock are affected by the percentage of fluid volume loss that patient has experienced. So hypovolemic shock can be divided into 4 classes or 4 stages. And to help you remember those stages / classes, remember the criteria numbers for each percentage loss. So the numbers you want to remember are 15, that's class 1, 15 to 30, that's class 2, 30 to 40, that's class 3, and then the last stage is 40%. Okay, so class 1. This is where the patient has lost less than 15% of their fluid volume, and that's about up to 750 mLs in an adult. Now, during this class / stage, the body can deal with this. It can compensate enough to maintain cardiac output. Now, because of that, your patient's really going to be asymptomatic with a fluid volume loss of less than this. Because remember, at the beginning of the lecture, I said that patients who have 15% or more are going to start showing those signs and symptoms of hypovolemic shock, because the body really can't compensate for that, and it has to turn on its sympathetic nervous system and all of that. So in this class / stage, how do you expect our heart rate to be? It's going to be less than 100. They're not going to have tachycardia. So it's going to be within normal limits, maybe a little bit on the high end, maybe 80s or 90s. Blood pressure, it's going to be within normal limits. Our body is maintaining our cardiac output. Respirations, within normal limits. We're not having any issues with decreased oxygen just yet, because our body can deal with this blood loss. Mental status, they're probably going to be normal. They may be a little anxious, but nothing major. Their skin is going to be warm to the touch. Their capillary refill is going to be less than 2 seconds whenever we check that. And their urinary output is going to be greater than 30 cc's an hour. So Kidneys are doing great. That's where we want them. Next, we have class 2, and this is where we've lost 15 to 30% of fluid volume. So anywhere between 750 to 1500 mLs in an adult. So with this, because we've lost more fluid volume than compared to here, our cardiac output is decreased. The body cannot maintain its own cardiac output with this amount of fluid volume loss, so it has to activate that sympathetic nervous system. The body's receptors in the body sense, hey, we can't do this, so those baroreceptors activate it. And that's in turn going to activate our renin-angiotensin system. You're going to get shunting of blood away from non-vital organs. So in a nutshell, what you're going to have is vasoconstriction from those catecholamines, from angiotensin 2. And this is going to constrict vessels, and this is going to increase venous return to the heart, which is going to increase our cardiac preload, stroke volume, cardiac output, and increase our blood pressure. So we're going to be maintaining tissue perfusion, making our cells happy, giving them oxygen. Also, we're going to be increasing blood volume through some hormones under the influence of angiotensin 2. So we're going to have ADH, the antidiuretic hormone, on board. That's going to cause us to retain water, and aldosterone, which is going to help us conserve sodium and water, and all that in hope of increasing blood volume in the blood, which is going to increase the venous return to the heart, preload, stroke volume, and cardiac output. So our signs and symptoms are going to really be around what's going on, because our body here is compensating with its built-in system. So how do we expect our heart rate to be? It's going to be increased because of the effects of the catecholamines on the heart. So we're going to have some tachycardia going on. It'll be mild. It's going to be less than 120, so less than 120. Our blood pressure is going to be decreased from where that patient normally is, but they're not going to be hypotensive just yet because this system's working to maintain our cardiac output, but it'll be slightly decreased. Our respiratory rate is going to be increased a little bit, just mildly, from everything that's going on. We've dropped in our oxygen, so the body's increasing respiratory to take in some more oxygen to help increase that level. Urinary output, well, what's going on with our ADH and aldosterone? It's causing us to keep water. So our urinary output is going to decrease. So instead of being the normal where we want it 30 mLs per hour, it's probably going to be between 20 to 30. So it's going to decrease. Skin. Now, we're diverting blood away from non-vital organs. The skin is one of them. So instead of our skin being warm and flush, it's going to be cool and clammy from where blood is being diverted. Capillary refill, the same concept there. Instead of being less than 2 seconds, it's going to be increased, so greater than 2 seconds. Peripheral pulses, because we're shifting blood away from those extremities, they're going to start becoming diminished and how we feel them. And mental status, instead of just being normal or maybe just a little bit anxious, they're going to start to have some mild anxiety going on. Next is class 3, and this is where the patient has lost 30 to 40% of their fluid volume. And this is anywhere between 1,500 to 2,000 mLs of fluid. Now, because it is this much, the body can no longer compensate. So compensatory mechanisms are going to fail. They're not going to be able to do it. And our cardiac output is just really, it has failed because they've lost so much blood in that circulatory system that the heart doesn't really have much to pump out and maintain perfusion. So you're going to see those cells that make up those organs and tissues, you're going to see malfunctioning of our body system. So we're ending up having failure. So our heart rate is going to be significantly high. It's going to be greater than 120. We're going to have tachycardia. Their blood pressure, they're going to have severe hypotension because we don't have the body being able to maintain blood pressure. So we're going to have some hypotension going on. Respiratory rate is going to be majorly increased. They're hitting respiratory failure territory, so they need mechanical ventilation intubation possibly to help assist them. Urinary output is going to be low, oliguria, so it's definitely going to be less than 30 cc's an hour. We're getting in the renal failure territory where BUN, creatinine is going to be increased. You're going to start seeing buildup of waste in the blood. Liver is going to be failing to help rid us of those toxins. In addition, perfusion to the brain, because our blood pressure is just so low, mean arterial pressure is going to drop, and so brain isn't going to be able to be perfused. So you're going to start seeing some major mental status changes. Here, you're going to see confusion, agitation, until it progresses to the next stage, where they'll be actually lifeless and a coma. Their skin is going to be cool, clammy, but even take it a step further, it can be mottled. And their pulses are going to be absolutely poor, their peripheral pulses. And the last stage we have is class 4. And this is where the patient has lost 40% or more of their fluid volume, so greater than 2,000 mLs. And this is where death is near. We need to get this patient some very, very fast treatment, dynamic treatment if possible, to help prevent that. And what you're going to see with this is just all these vital signs that we're talking about, they're going to be significantly abnormal. So you're going to have major tachycardia, greater than like 140, severe hypotension, major respiratory failure. They're going to be anuric. They're not going to be producing any urine. There's like hardly any fluid to even produce fluid for urine off of. Mental status, like I said, they're going to be lifeless and in a coma. So in a nutshell, whenever you're looking for signs and symptoms, like for your exams for hypovolemic shock, you need to be looking at that heart rate. How's it going to be? It's going to be high. It's going to be tachycardic. How's their blood pressure going to be? Hypotensive. Respiratory rate is going to be increased. Their urinary output is going to be decreased. Their skin perfusion, it's going to be cool, clammy, capillary refill is going to be down, mental status is going to be confused. So be keeping all that in mind. And whenever a patient, whenever they have like hemodynamic monitoring, whenever they start getting in these classes of hypovolemic shock, they're going to have that hemodynamic monitoring. So whenever we're looking at central venous pressures, how do you think that number is going to be? It's going to be low. This is where you measure the pressure over here in this right atrium. We don't have any fluid, hardly even in the heart. So the pressure there is going to be low. And if you looked at a pulmonary capillary wedge pressure over here, which looks at the filling pressure in the left atrium, it's going to be low as well because we're depleted of our fluid volume. So remember those two numbers. And it's different whenever we talked about cardiogenic shock. Remember, I talked about the CVP being high, that central venous pressure, and that pulmonary capillary wedge pressure being high. Because cardiogenic shock, we don't have a loss of fluid volume. Our heart's just weak, and that fluid volume, the pressure of it is actually increasing. We're going to have fluid volume overload. So those numbers would be high in cardiogenic shock. Now let's talk about nursing interventions for hypovolemic shock. Okay, what are some treatment goals first? Because that really dictates where we're going with our nursing interventions. One thing, of course, is replacing fluid to this intravascular system. If we can increase the venous return to the heart, we can increase preload, stroke volume, and increase cardiac output, and we get better tissue perfusion. So fluids ordered by the physician are really going to help this patient. And as a nurse, we will be giving those fluids and monitoring them. And it can vary. It depends on what class or stage of hypovolemic shock that patient is in. And you can use various fluids like crystalloids, colloids, blood products. And we'll be talking about all those here in a moment. And of course, correcting the underlying cause of the reason why that patient is losing so much fluid from the intravascular system. So if they're having a massive bleed somewhere, they need to have surgery, repair that to stop the bleeding. So nursing-wise, we're looking at a lot of things. We're looking at circulation, perfusion, oxygenation, and we're going to put our nursing interventions and goals for that patient around that. So oxygenation-wise, we want to make sure that they're getting oxygen because O2 is a problem here because those cells are being deprived. So we want to make sure that they're not entering into respiratory failure, so they may need intubation, mechanical ventilation, placed on oxygen. Circulation-wise, are they actively bleeding? they are, you want to hold firm, direct pressure, call rapid response, get someone there to help you fast because you need a team to help you with this patient. In addition, simultaneously, you're going to be doing all this. You're going to be looking at signs and symptoms of adequate perfusion. Is this patient going into hypovolemic shock? So you're going to pull from those signs and symptoms that they are. And very simple, you can look at their skin, cool and clammy, that would be bad. Look at their mental status, how are they acting, what's their blood pressure, their heart rate. Remember, blood pressure will be low, they can be tachycardic, heart rate will be high. Urinary output, what are they putting out? And looking at all those things. In addition, you want to make sure that you have IV access. We need access to that intravascular system so we can give them fluids and drugs, whatever we need to get that cardiac output up, replace that fluid. So you need at least 2 IV sites, and they need to be a large cannula there in those large veins, those antecubital veins, the ACs. At least 18 gauge or higher. You're going to be giving rapid fluids, fast, and other medications, so we want to make sure that they're nice and working. In addition, they may need a Foley catheter so you can monitor that urinary output, precisely collect that instead of depending on the patient to use the bathroom, which they're probably going to be so sick they can't do that, and we want to be able to collect that. And many patients who have severe hypovolemic shock, they're not responding to the fluids. We're going to have central lines, hemodynamic monitoring, which will help us monitor the cardiac output and how well we're replacing those fluids. And we can look at some numbers. So whenever you have a patient in hypovolemic shock, severe hypovolemic shock, how again is that central venous pressure going to be? It's going to be low. How's that pulmonary capillary wedge pressure going to be? It's going to be low. But we're giving them fluids. So one thing, whenever you give fluids, you have to make sure you're not giving them too much, where we're going to actually flip them into cardiac fluid overload. So if we were giving them too much fluid, how would those numbers start presenting? Central venous pressure can start becoming elevated. The pulmonary capillary wedge pressure can start becoming elevated as well, because putting too much fluid in the heart, it's too much, so it's increasing the pressure over here, or right atrium, so CVP pressure, and the filling pressure in the left atrium for pulmonary capillary wedge pressure. So you want to look at those things. Now, position-wise, what's a good position for these patients? We want a position that's going to increase cardiac output, venous return to the heart. So one position is modified trendelenburg. This is where the patient is supine with their feet/legs elevated at that 45 degrees. Doing that is going to increase venous return and help us increase cardiac output a bit. Lab-wise, we have to monitor what's going on with the patient, so physicians will be ordering this, and we'll want to be either collecting that, looking at those labs coming out. Hemoglobin, hematocrit, looking, does this patient need blood products? Depends on protocols, but usually less than 8 to 7 for hemoglobin. They'll need some blood transfusions. ABGs, arterial blood gases. Remember, these patients can go into acidotic conditions. We want to be looking at that. Looking at lactate levels, because our cells are switching from aerobic to anaerobic. We're going to get the buildup of lactic acid. Livers may not be working, building up more toxins, or kidneys. Looking at electrolytes, CBCs, looking at BUN, creatinine, telling us our renal function. Now let's talk about our fluid types used for the treatment of hypovolemic shock. Okay, first thing we're going to talk about are crystalloids and colloid solutions. These are 2 types of volume expanders used for hypovolemic shock, and again, this varies depending on the patient's status, volume loss of what will be used. So first let's talk about crystalloids. Okay, crystalloids. What is a crystalloid? Well, normal saline or lactated ringers, and how they work is that they add more fluid to the intravascular system, and this is going to increase preload because it will increase how much fluid's coming back to the heart, and stroke volume and the cardiac output. So with this, you have to watch for fluid volume overload, like I was talking about earlier. And you can look for many things just simply listening to their lungs. You hear fluid in the lungs with crackles. They having difficulty breathing? Are they having elevated CVP pressures or pulmonary wedge capillary pressures? or just looking for edema in legs, or do they have jugular venous distension? Things like that can point to that they're retaining too much of the fluid. And one thing about crystalloid solutions I want you to remember is that these solutions are able to diffuse through the capillary wall. So less fluid remains in the intravascular system compared to colloid solutions. Now, normal saline or lactated ringers are most commonly used. Number one, they're really cheap, easy to access. And how they're given is by remembering the 3-to-1 rule. And what this rule says is for every ml of approximate blood loss, 3 mLs of a crystalloid solution is given. So let's say a patient has lost 750 mLs of blood. How much of a crystalloid solution would they give? Well, according to that rule, it would be 2,250 mLs because we're going to be giving 3 mLs of a crystalloid solution for every ml of blood lost. Another fluid type is colloids, and an example of this is like albumin or hetastarch. And what colloids are, they consist of large molecules, examples like proteins, that can't diffuse through a capillary wall. So in the long term, more fluid stays in that intravascular system for a longer period of time compared to those crystalloids. However, colloids are more expensive to use and patients can have anaphylactic reactions. So again, just with crystalloid solutions as well, you would want to monitor for fluid overload. Now, as a nurse, it's really important to remember if you are giving large amounts of fluids like these crystalloids, colloids, it's very important that you warm them before giving them, because this will prevent hypothermia. And we don't want a patient to go into hypothermia because hypothermia alters the way clotting enzymes work. So we want to keep the patient warm, keep the fluids warm, but we don't want the patient sweating. So remember that whenever you're giving large amounts of fluids. The last fluid type we're going to talk about, of course, is blood and blood products. This can include packed red blood cells, platelets, or fresh frozen plasma. Now, packed red blood cells are going to help replace the fluid that has been lost, and it's going to do another thing that really our crystalloids and colloids couldn't do. It's going to provide the patient with hemoglobin, and hemoglobin will carry oxygen to those deprived cells. So that is one benefit of that. Now, it may be used when the patient is not responding to crystalloid fluid challenge, has experienced severe bleeding, or severe hypovolemic shock. And some other type of blood products used are like platelets, and these would be used for patients who are having uncontrolled bleeding due to thrombocytopenia, so they need some platelets to help with that. Also, fresh frozen plasma. This is for when patients need clotting factors. Now, anytime you're giving any type of blood products, you always want to monitor for transfusion reactions with these products. And I have a whole video on the nurse's role with blood transfusions if you want to check that out as well. Okay, so that wraps up this video over hypovolemic shock. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.